66-year-old postmenopausal woman underwent mastectomy for a 5.5 centimeter, grade 3 ER-positive, PR-positive, HER2-negative invasive ductal carcinoma with 5 positive axillary lymph nodes. She completed adjuvant chemotherapy and is initiating endocrine therapy. Her oncologist discusses adding a CDK4/6 inhibitor. The addition of a CDK4/6 inhibitor like Abemaciclib or Ribociclib is definitively proven to improve overall survival in the adjuvant setting for high-risk early breast cancer. Answer: false. While trials like monarch-E, Abemaciclib, and NATALEE, Ribociclib, have shown improvements in invasive disease-free survival, IDFS, follow-up is relatively short, and a statistically significant overall survival benefit has not yet been demonstrated. This patient meets the high-risk criteria for consideration of adjuvant Abemaciclib based on the monarch-E trial eligibility. Answer: true. The monarch-E trial defined high risk as having greater than or equal to 4 positive nodes or 1 to 3 positive nodes plus either tumor size greater than 5 centimeters, histologic grade 3, or Ki-67 greater than or equal to 20. This patient meets the criteria with 5 positive nodes and also with tumor size greater than 5 centimeters and grade 3 disease. Adjuvant palbociclib demonstrated similar efficacy to Abemaciclib and Ribociclib in large phase 3 trials for high-risk early breast cancer. Answer: false. The PALLAS and Penelope-B trials, which evaluated adjuvant palbociclib, failed to show an improvement in IDFS and were stopped early, PALLAS, or reported negative results. Is adjuvant olaparib the preferred targeted therapy addition for this patient instead of a CDK4/6 inhibitor? Answer: no. Olaparib is indicated for patients with deleterious germline BRCA mutations. There is no information provided about this patient's BRCA status, and CDK4/6 inhibitors are considered based on clinicopathologic high-risk features in the absence of a BRCA mutation or if BRCA status is unknown or negative. If ribociclib is chosen, should it be administered continuously alongside endocrine therapy for 2 years? Answer: no. Adjuvant ribociclib, based on the NATALEE trial, is approved for 3 years and is given on a schedule of 400 milligrams daily for 3 weeks, followed by 1 week off. Adjuvant abemaciclib is given continuously for 2 years. Are grade 3 or higher adverse events significantly more common with the addition of abemaciclib compared to endocrine therapy alone? Answer: yes. In the monarch-E trial, the incidence of grade greater than or equal to 3 adverse events was substantially higher in the abemaciclib plus endocrine therapy arm, 50%, compared to the endocrine therapy alone arm, 16%. A 71-year-old postmenopausal woman completed 5 years of letrozole following surgery and radiation for a 1.2 centimeter grade 1 node-negative, ER-positive, PR-positive, HER2-negative invasive ductal carcinoma. She tolerated letrozole well apart from mild vaginal dryness managed with moisturizers. She asks if she needs to continue endocrine therapy longer. Extended endocrine therapy beyond 5 years is strongly recommended for all patients with ER-positive breast cancer, regardless of initial stage or risk factors. Answer: false. Extended therapy is an option, but the decision requires balancing recurrence risk against side effects. For women with smaller node-negative tumors, low risk, the benefits are less clear and may not outweigh toxicity risks. Continuing letrozole for an additional 5 years, total 10 years, has been proven to significantly improve overall survival in postmenopausal women who completed an initial 5 years of AI therapy. Answer: false. While the MA17R trials showed that extending letrozole for 5 more years after approximately 5 years of AI improved DFS, no trial has demonstrated an overall survival benefit for extended AI therapy after an initial 5-year AI course. The risk of bone fractures is expected to decrease if this patient continues letrozole for an additional 2 to 5 years. Answer: false.
Extended AI therapy is associated with increased bone-related toxic effects. The MA17R trial showed higher rates of fractures, 14 versus 9%, and new onset osteoporosis, 11 versus 6%, with extended letrozole versus placebo. The ABCSG16 trial also showed more fractures with 5 versus 2 years of extended anastrozole. Is it considered reasonable for this patient, given her low-risk disease features and good tolerance, to stop endocrine therapy after 5 years? Answer: yes. For women with smaller node-negative tumors, stopping endocrine therapy after 5 years is a reasonable option, particularly if they wish to avoid ongoing side effects and risks, as the absolute benefit of extended therapy is likely small. If this patient strongly desires further risk reduction and is tolerating letrozole well, would continuing it for an additional 2 years, total 7 years, be an appropriate consideration? Answer: yes. If extended therapy is chosen for low-risk patients, an additional 2 years, total 7 years, is considered appropriate as the benefits of extending to 10 years appear minimal in this group while toxicity risks persist. Are gene expression assays like the Breast Cancer Index routinely recommended to guide the decision about extended endocrine therapy for this specific patient profile, low anatomic risk? Answer: no. While weak recommendations exist for potentially using BCI, routine use is not endorsed, especially as a primary driver for decisions. It might be selectively used to aid discussion if the patient is uncertain despite low anatomic risk.
What topic should we bite next? Comment below. Subscribe and hit the bell for instant updates. Explore our channel for more. Find more info at HemOncBytes.com. Stay current, stay curious.